morning, everybody. It's a great pleasure to be here with such a big audience today. Everybody is very energetic. I think the quality is important rather than the quantity. So we have floated yesterday in the immense sea of knowledge, science about various liver diseases. Today we will fly with such good speakers. So we have first Professor Jessica Mellinger. She is from Herringford Health, Michigan State University. She's a senior staff physician, associate professor in internal medicine and psychiatry, where she practices clinically in general and transplant hepatology with a special focus on alcohol-related liver disease. She holds her medical degree from Northwestern University Feinberg School of Medicine and master's degree in English literature, that's interesting, and history of medicine from Oxford University. Congratulations for that. Healthcare research she got from she makes in the University of Michigan. Her clinical practice and research focuses on the epidemiology of alcohol-related liver disease, cost effectiveness and access to alcohol use disorder treatments among those with ALD, and developing novel behavioral interventions to help patients with alcohol-related liver disease stop alcohol use and engage in alcohol treatment. Along with colleagues in psychiatry, in 2018, she founded the Michigan Alcohol Improvement Network's multidisciplinary ALD clinic, great achievement. One of the first fully integrated, co-located alcohol and liver disease treatment for ALD patients in the United States. She is funded by NIAA to study behavioral treatments in alcoholic liver disease. The chair is yours, Jessica.
Okay, got it. Is that better? Okay. I was saying I won't be talking about medieval English literature today, so we'll not bore you all, but it's, yeah. I can mention some Chaucer if you'd like me to. No, kidding. No, it's a real honor to be here in Istanbul. This is my first time here, and it's been such a treat. Everybody's been really lovely, so I really appreciate the invitation and the wonderful hospitality. So thank you so much. This will be the ALD debrief from the liver meeting. So we'll be talking through a few kind of high-impact abstracts that were presented. There were over 300 abstracts submitted, which is a very good number, but I will note this is about 1/5 the number of abstracts that get submitted for metabolic liver disease. So in the world of liver disease, despite having some of the highest impact in terms of economic burden, healthcare burden, and personal burden of our patients, alcohol-related liver disease gets less attention relatively in terms of research. So we'll be looking at some different themes here about improving how we look at alcohol measurement, and then also transplant, and then some interventions to treat alcohol use in ALD. And you'll notice that the intervention component is a little bit less than the observational component. So I think there's work to do in the field here in terms of more intervention to help our patients. So starting off with the observational studies. This was a study looking at long-term outcomes following a hospitalization for acute alcoholic hepatitis. Retrospective single-center study from South Carolina. This was from the Medical University of South Carolina. And they looked at approximately a 10-year history of patients who were admitted with severe acute alcohol hepatitis, so high MELD, over 21, and they actually had liver biopsy on all of these patients and hepatic venous pressure measurements. So one of the key questions that we often have in ALD is what's going to happen to people after they get discharged, right? Who is going to get better? Who isn't going to get better? Who is going to need transplant? Who's not going to need transplant? So they looked at this in a retrospective fashion, and they found that the mean MELD was approximately 27. Maddrey's was quite high, the Maddrey's discriminant function at 68. About 16% were non-cirrhotic, and so this really matches some of the liver biopsy data that has come out from Europe, where they do a lot more liver biopsy. So the clinical care of acute ALCHEP in the United States is that we almost never biopsy these patients. In Europe, quite different. They biopsy much more frequently. And in this population, they have found about 85% have high-grade fibrosis or cirrhosis. So typically, when I see patients like this coming out of the hospital, I assume they have cirrhosis or high-grade fibrosis, even if I'm not certain about it. And here they found very similar. So again, about 85% had high-grade scarring, high-grade fibrosis or cirrhosis. And the baseline pressure gradient was roughly similar, a little bit higher, as you might expect in those F4. When they looked long-term at this 10-year follow-up, they found that roughly about 44% of those who achieved abstinence to alcohol died, as against 84% who were alive, So, and the abstinence was a key feature of determining if you remained alive at the end of this time period. For those, they also looked at recompensation. So this has become a key feature of, again, trying to predict what's going to happen to these patients and picking out the people that will need transplant, right? We could take all of these patients, and in the United States, almost every single liver transplant center is transplanting patients with less than 6 months of abstinence under certain criteria, and we'll talk about that later. But who should we transplant and when? Because some people get better. So if we transplant everybody at time point 0 when they come in, we will absolutely be transplanting people who will get better. Some of those people would improve, but it's hard to know who those folks are going to be when you're meeting them for the very first time. So in this case, what they found was that it was actually pretty rare that people recompensated. About 1 in 10, around about 12%, came fully back to have full recompensation, resolution of ascites, normalization of labs. And again, for those who had abstinence, who stopped drinking, it was much higher as against those who did not. So the takeaway here was that, again, most of these patients who have acute alcoholic hepatitis have cirrhosis. Very rarely will you see folks that don't. And they're pretty much clinically indistinguishable from those who does and who doesn't. It's hard to tell without a biopsy. Lower baseline MELDs, abstinence from alcohol, those were associated with long-term survival. And that recompensation, that full recompensation, is pretty rare, but where it does happen, it's abstinence. That gets you there. It's really stopping alcohol use. So again, if we're looking at transplanting patients or trying to figure out who to transplant, we want scores. We've been trying to find scores to predict this, to predict who's going to drink again after they get an episode of this. Because all of the best data shows very clearly from this and from other studies, prospective studies as well, that patients who survive an episode of acute ALK-HEP in the hospital who go back to drinking have substantially increased mortality. It's the single biggest factor that leads to death in these patients. So we've been trying to find predictive models for patients and who's going to drink and who's not going to drink. And this was a study that came out of the ALK-HEP-Net. And ALK-HEP-Net is a very large NIH-funded consortium of hospitals that has been funded by the NIH for probably 15, 20 years now, looking at patients with acute ALK-HEP, what happens to them prospectively, and then trying to develop and find interventions for them. So this was a nice prospective follow-up to almost a year, so 200 days, and they looked at return to drinking, and they measured it really well. So timeline follow-back is a calendar-based method. It's really labor-intensive. So I do it in my research studies. It takes a lot of work. So it's really only done in research, but you basically ask patients, on the 1st of the month, how much did you drink? On the 2nd, how much did you drink? On the 3rd, how much did you drink? So you can imagine how this goes, right? We figured out a way to do this electronically and shoot them a calendar, so it's gotten better, but they did this right. This is the gold standard for measuring alcohol use. They did a good development and validation split to find out if this worked, and they called it the MIRAGE score, M-E-R-A-G-E. And they found that in about 350 patients, about 28% returned to drinking over that time frame. That's again about roughly what we see from other epidemiologic studies, so no big surprises there in terms of the numbers. And what they found was that a combination of MELD, Ethnicity and race. In the United States, ethnicity is a census category that's categorized as Hispanic or non-Hispanic. Race is categorized as white, Black, Asia Pacific Islander, Native American. Age, gender, and education level, and they found that this had the characteristics that you see here performed a little bit better than the high risk for alcohol relapse score. So a valiant effort, again, to predict post-acute ALCAP relapse. But like a lot of these tools, and there are many of them, it doesn't do very well at predicting who is going to drink. It does a nice job at getting your negative predictive value. So it's pretty high, right? 88.88 on the negative predictive value. So it does better on who's not going to drink, right? Not necessarily on predicting who is going to pick up that next drink. And that has been a real limitation to almost all of the relapse prediction measures that have been developed over the past 20 years, is they don't perform that great at telling us what we really want to know, right? Who is going to drink, not necessarily just who's not going to drink. So the other aspect of this case that I felt was important, or this presentation, was that they didn't do phosphatidylethanol or tox screen. So phosphatidylethanol is a blood-based alcohol measure that picks up alcohol about 2 to 3 weeks back. Urinary ethyl gluc is a urine-based alcohol measure that gets alcohol use about 3 to 5 days back. We like to use these more and more, and we hope to use them more and more in research because there is a high discordance rate, meaning people will tell you they're not drinking, but they are. That discordance rate is about 30 to 50% in the studies. So take those numbers and think about 30 to 50% of those patients who said they weren't drinking may actually be drinking if we did PEth in all of them. Now, why don't we do PEth? And again, I do NIH-funded studies. It is expensive. So you don't want to blow your budget on one test, and so that's often why this doesn't get done in studies, or we use just standard of care measures. So great work by this group to try to find an even better way of figuring this out for us. And then they had, whoops, I just went too far, excuse me. This next one, I didn't mean to segue so well into phosphatidylethanol, but I did. The next abstract is all about phosphatidylethanol and kind of what it actually looks like in the real world. So this was done at the Harvard Brigham system, about 5,000 patients, again, not all with ALD in this case. And they looked at who had PEth testing between 2022 to 2024. In the United States, we didn't do PEth testing until pretty recently, probably about the past 5 to 10 years, I would say, probably more like 5 years, has it really picked up clinically, where hospitals have it now, we can use it, we can order it. So now we're getting more and more data on kind of what does this actually mean. They found here that the median PEth level was actually quite high, 251 nanograms per ml. Anything over about 200 has been associated in the literature, including in liver disease patients, with heavy drinking. So 4 drinks per day or more is typically 200 or higher. So that's a pretty high level on average for this cohort. It was highest, as we expect, in the younger cohorts, and this is what we see when we look at age cohort alcohol epidemiology. Younger patients tend to drink more, and then as people age, that tends to go down broadly. So this sort of fit with that alcohol epidemiology. But really no difference between men and women, though there's been some postulated differences in PEth metabolism between the sexes. They did find that the correlation between PEth and self-report was not the greatest. And again, the correlation was a little bit lower for women versus men. So in the real world, what we saw here was that, again, the PEth levels were a little bit higher than had previously been reported, and that suggested that the heavy alcohol consumption may be more prevalent than we expect. And again, this fits with these discordant rates, 30 to 50%. In the younger individuals, it was a little bit higher, but again, no difference between men and women. And this poor correlation between self-reported alcohol use and PEth, again, suggests that we need better ways of talking about alcohol with our patients to get more discussion about what they're really drinking and what that really looks like when they talk to us. So in this study, we looked at, this was from the Accelerate group. So this is a 10-year post-transplant outcomes after early liver transplant for ALCAP. The Accelerate group is a group of about 10 or 12, I think, US transplant centers that have pooled all of their short sobriety alcoholic hepatitis patients retrospectively to look at outcomes. So it is, in the US anyway, one of the largest collections of patients who've been transplanted with less than 6 months of sobriety at the time of evaluation. And so they've now looked at 10-year outcomes to see how people have done. So as many of you know, the debate about transplant for short sobriety for patients with less than 6 months of abstinence has centered around, initially, how do they do long term? Do they live as long? And that debate has really been settled. They do. They live well. They have mortality and survival that is equivalent to standard patients who have more than 6 months of abstinence, and they have mortality that is equivalent and sometimes even better than transplant for other indications. So the mortality question has really, in my mind, been settled. Now we're looking more at these drinking outcomes and what happens long-term to their relapse risk and so forth. So what they found here, again, similar to what we found in other studies, is that the long-term survival is actually quite good. You know, a year at 94% at 1 year, 83% at 5 years, excuse me, 70% at 10 years, and about 16% had a prior liver decompensation that they drank over. This becomes important because the criteria that many centers use was based upon something called the Dallas criteria. So this was a conference that was conducted in Dallas about, I think it was 8 years ago. I think I was very junior faculty when I participated in that, so it was a long time ago. And they set out some criteria. We set out some criteria in that conference for if a center wanted to do this, how should one do it? And not drinking over a decompensation was considered a criteria that should eliminate one from consideration for short sobriety transplant. But some of these patients did get in with that criteria, so they got to see kind of how they did. So in here we look at return to alcohol use. So you can think of it like this. About half of the patients who get transplanted will use alcohol at some point within the next 10 years. This agrees with work that Andrea DiMartini, a psychiatrist at Pittsburgh, did over 10 years ago that looked prospectively at ALD patients post-transplant, also found similar numbers. About half drink to some degree. About a third drink heavily. So the kind of heavy alcohol use that can destroy the graft and lead to cirrhosis. And that's what we see in the graph to your right. So that red bar shows those patients who drank in a harmful way die much sooner after transplant. The patients who drink, but even in a non-harmful way, so that not heavy way, they're dying a little bit sooner too, long term. Those who are able to abstain survive the longest, and about a quarter of those deaths were alcohol related. So here what we saw was they looked specifically at some of these criteria that we had to see which were associated with post-transplant survival on your left here versus post-transplant alcohol consumption on your right. And you can see actually that those who had that prior liver decompensation and then drank over that, they had worse outcomes, worse survival. They were 3 times more likely to die as against those who didn't. As you can imagine, as we saw, anybody who used alcohol either at all or heavily was more likely to die and have worse survival. And then in terms of the risk for post-transplant harmful use, so that red line that you saw, if you had more alcohol rehab attempts, and this is usually interpreted as maximal therapy. So when I think about treating alcohol use, I think about it similar to treating cancer, right? Some people have an early stage cancer that's easier to treat. They don't need a long course of chemo. They don't need a lot of surgery. They get a little bit of treatment and it gets it under control. And then some people have stage 4 metastatic cancer, right? They need a lot more to get that under control. The same is true for alcohol use disorder. Some people have mild alcohol use problems and a little bit of treatment, they will be great. Others need more advanced treatment, more intense treatment. So it makes sense to me that people who have more rehab attempts are people who are harder to treat. They had to go back again and again to get residential rehab, to go to intensive outpatient programs. These are your high-intensity chemos, your high-intensity radiation, like you're hitting them hard at the top. They drink over that. That's someone who has a more severe alcohol use disorder. You might have more problem treating that post-transplant. So not the patient's fault, right? They have an alcohol use disorder. It's tough to treat, just like sometimes folks have tough to treat cancers. Not their fault. But some patients have that, and it makes it harder for them to be treated. They drink. They're more likely to drink afterward. So looking at a couple of intervention studies, in this intervention study, this was a propensity-matched analysis of how did naltrexone perform against acamprosate in patients who had cirrhosis. So this was a retrospective analysis, and they used a propensity matching, which is kind of almost, it's not quite a clinical trial emulation, where you can kind of take observational data and approximate a trial, right? So they did that with a propensity match where they matched against naltrexone and acamprosate, and they found that naltrexone versus acamprosate had lower all-cause mortality over the course of the 5 years with no differences in GI bleeds or admissions. So naltrexone maybe performs a little bit better in this cohort as against acamprosate. Naltrexone does seem to perform in the alcohol use literature a little bit better in patients who are recently drinking or actively drinking. So your kind of active drinkers, your early sobriety folks, naltrexone seems to perform a little better in those. Acamprosate seems to perform a little better for maintenance of abstinence. So you've established abstinence, acamprosate helps to maintain it. But quite frankly, I use whatever my patients will accept and whatever their insurance will cover. So that's what we get to decide. That's how we do it in America. We have to go with what their insurance will cover. And then finally, the last slide that I had, the last study that I have here is looking at incretin-based therapies and post-bariatric alcohol use disorder. So this, again, another propensity-matched cohort. So again, we're looking at observational retrospective databases, trying to make, sort of emulate clinical trials out of that. They looked at after bariatric surgery. Does getting on these incretin-based therapies lower the risk of alcohol use compared with other anti-obesity medications? And this becomes really important, kind of sets up Dr. Bonsall nicely for her talk on MET-ALD when we think about the comorbid conditions of obesity and alcohol use. In the bariatric surgery world, it is well established that folks who have bariatric surgery have higher incidence of alcohol use and alcohol use disorder after that surgery. The metabolism of alcohol changes, and there may be some switching of addictions, right? We go from having food addiction to going from having alcohol addiction. So this again looked at a retrospective cohort with the TriNetX group or population, bariatric surgery patients who received an anti-obesity medication, and they looked at incretins versus non-incretins. So obesity medications, one versus the other. They looked for new onset AUD and initiation of these medications. And what they found was that incident AUD was a little bit lower amongst those who were on the incretin therapies versus those who were on the other anti-obesity measures. And that medication initiation for AUD in these populations was, again, a little bit lower for the one versus the other. So incretins may confer neurobehavioral benefits. I think there's a lot of interest in this right now. There's a lot of clinical trials right now on these GLPs and how do they function in addiction specifically. There are some clinical trials in the US for alcohol use primarily as a primary indication. I get patients in my ALD clinic asking fairly frequently, can I get a GLP? Can I get Ozempic? And deal with their alcohol and their obesity at the same time. And I tell them, if you have a few $1,000s a month, sure, go ahead, but they're not gonna cover it for that right now. So I think there's a lot going on there. And then again, I would just leave you all with this. You know, ALD, again, at least certainly in the United States, is one of the biggest burdens for liver disease that we have. And yet, there are so few intervention studies in this population to really find interventions, whether pharmaceutical or otherwise, that are going to help them. So I think this is a real area where we need some work. So thanks.
Thank you so much, Jessica. It was a very comprehensive talk, giving inspiration for further studies. Maybe we can have 2 questions before you leave the scenery. Yeah, 2 questions, because the time is limited by the organizers. So anybody who wants to ask a question, please.
Thanks for the comprehensive speech. How do incretins have neurobehavioral benefits in this population of patients? What's the mechanism?
Well, I actually think we're not entirely certain how they are having a benefit on the neurobiological mechanisms of addiction. That isn't really known right now yet, why some people, when they go on incretins, experience dramatic drops in their desire to use alcohol or to eat. They're actually exploring them for all kinds of compulsive behaviors now, but it's not entirely clear precisely how they do this. But in some patients, they very clearly do, not everybody. Yeah.
Thanks.
Yeah, no problem.
There's a theory about that.
Yeah, go for it.
It's that in hypothalamus, I mean, the satiety center, I mean, the
Satiety, yeah.
Satiety center
Yeah.
is very close to the desire center. So they believe that it affects the desire that they're feeling from alcohol.
Nice.
So they believe that there are neurons that affects each other, so that's why they don't drink. And other than that, I mean, I think they have side effects when they drink.
Absolutely.
So they blunt all the desires, Yasemin?
It's true. They're actually looking at them for like gambling addiction and some of these behavioral addictions too. Yeah, smoking. I mean, they're going to be in the water everywhere now, and we're all going to be thin and everything's going to be great when they get them there.
Thank you for the speech. It was really excellent.
You're welcome.
We were thinking that Turkey is metabolic steatotic liver disease country, but nowadays we are getting much more alcohol-related disease. So it's an issue for Turkey also. I wonder whether naloxone and GLP-1 analogs may have synergistic effect when they use together. What's your experience on this? And
Yeah, absolutely. So I think they absolutely could, because provisionally they're working on different mechanisms. So I have not in my practice used both at the same time. When I've had patients come into our clinic on the GLPs, on the incretins, if they tell me that that's taking care of their alcohol use, like they don't want to drink, I generally don't add anything to it. I just say, okay, great, like we'll just keep you on that. But I think you absolutely could add naltrexone to an incretin without a problem. We routinely use multiple relapse prevention medications. So we will often use naltrexone or acamprosate and gabapentin, for example. So gabapentin is not FDA approved for alcohol relapse, but it has data to show that it does have that effect. So we'll often kind of stack these medications to deal with neuropathy, anxiety, mild withdrawal, and then especially if people are drinking over one, we might add another in addition to getting them into behavior therapy. I will say that the data on the alcohol treatment medications, which I'll go over in my next talk, almost every single study, those medications have been studied with behavioral therapy, so with psychotherapy. So it's the two together that's really powerful.
And second question is that we know that...
Short question, short answer.
Yeah. You mentioned that you assume all patients have cirrhosis. But in my clinic, I usually first try to rule out cirrhosis. Do you think the cirrhosis in this patient, I mean acute alcoholic hepatitis patient, is different than the regular alcohol-related cirrhosis? Since I believe it's reversed very easily.
So I think if they have cirrhosis, and I think you're absolutely correct to formally assess that, when they're far enough out of drinking and out of the inflammatory phase of that, to assess it with non-invasive testing, elastography. I don't know that I think it's different once we see it there. I think the reversibility aspects of it that I've encountered are largely around the inflammation. As that goes down, portal pressures improve, the symptoms can get better, but often patients are still left with cirrhosis, which then sort of behaves very similar to, in my experience, the cirrhosis that I've seen otherwise. Thank you.
Okay, very short question.
Thank you very much for this excellent presentation. Very short question. Incretin therapies are known to cause sarcopenia, and alcoholic patients are also very prone to sarcopenia. So where should we stand regarding the therapy? for those patients.
Using it in these patients. So I think it needs to be accompanied, and this really goes for kind of all patients, and I think Dr. Bonsall will probably address this as well when she talks about Met ALD. They really need to have high protein diets, and they need to be doing, if they can, ideally some type of strength training to keep the muscle mass up, because it is very true that these medications cause sarcopenia, and in my patients who are already decompensated, you know, they're really prone to losing a lot of muscle mass. So my recommendations for them are probably even more strong to increase their protein, increase their, you know, strength training, physical therapy to keep that muscle mass on as they can. Thank you.
Okay, we give a big applause to Jessica, and I hand over the microphone to my colleague.
And second speaker is Dr. Meine Bansal. Yesterday her CV was presented, but I still want to mention it briefly. Dr. Bansal has been on faculty at Mount Sinai since 2001, quarter century. It's very interesting, and same place. She's currently focused on the treatment and management for those MASH. She has served as a principal investigator for numerous clinical trials for MASH and has been greatly involved with bringing new therapeutics to patients. And also she held the position of Secretary ASLD and currently serves as the director of newly formed Muscle MASH Center of Excellence at Mount Sinai. The topic is Met ALD as a distinct clinical entity, diagnosis and management. Yes, please.
Thank you so much. These are my disclosures. And again, some of this material was presented during the liver meeting by Dr. Siddiqui and Dr. Brian Lee. So I'm going to first talk a little bit about the definition of Met-ALD, and I would say it's really a dynamic continuum and a work in progress. Impact of alcohol on metabolic risk factors, the synergistic effect of alcohol and metabolic risk factors in driving fibrosis progression are all cardiometabolic features created equal. The management of Met-ALD really having a need for a holistic treatment, and I think Jessica and I will be overlapping because she'll be talking about alcohol use disorder treatments, and then a few abstracts that focused on Met-ALD. It didn't have its own debrief. So we know that the nomenclature really set up an infrastructure for us even to think about Met-ALD, because we know that people who have metabolic features or dysfunction drink, and often more than they say they do. And on the other hand, patients with alcohol-associated liver disease have metabolic risk factors that we need to address. So Met-ALD is defined as we went over a lot of these cardiometabolic risk factors yesterday, but then in terms of alcohol consumption, you can see in terms of the grams per week, that range of 140 to 350 that translates to 1.5 to 3.5 drinks per day for females. And for males, 210 to 420 grams per week, 2 to 4 drinks per day. And as Jessica pointed out, that's self-reported. You know, these are based on Audit C and self-report of drinking, but patients underestimate their drinking. So there's really a movement towards using more quantitative PEth values, as she described, where over that 200 or 210 threshold is really considered more alcohol-associated liver disease. I always make this point when I give a talk about fibrosis because I think this concept is extremely critical. Most patients, it takes 30 years to develop cirrhosis, but in some, they will develop cirrhosis in as little as 10 years, and some will never develop cirrhosis, irrespective of the etiology. And we know this very clearly from hepatitis C. Patients could have a blood transfusion when they were in their teens. They've had the virus circulating for 60 years, and they have no fibrosis. So when we talk about determinants of fibrosis progression, there is a genetic predisposition. Are you a fast fibroser? Are you a slow fibroser? And we know that there are some SNPs that are associated with that in the world of alcohol as well as MASLD, such as PNPLA3, HSD17B13, TM6SF2, just to name a few. But the idea is you're born a slow, intermediate, or rapid fibroser. Superimposed on that, there are cardiometabolic risk factors. There's impacts of social determinants of health, the air you breathe, the food you drink. Do you smoke? Do you drink coffee? And then why we're here today, the interaction between alcohol and cardiometabolic risk factors. So somebody who's born a slow fibroser may actually become a rapid fibroser and vice versa. So when we think about the synergistic impact of alcohol on increased stages of decompensation across fibrosis stages, on the bottom you see you have that cardiometabolic risk factors, you have the genetic risk factors, and then you have increasing progressive use of alcohol. And you can see along that dynamic spectrum of SLD, as you increase that alcohol consumption and you look at fibrosis stages as measured by transient elastography on the left, you see that there's increased risk of decompensation with increased alcohol use. We know from both the Danish prospective study and the Finnish population study, there's a steady decrease in overall survival as you move from MASLD to MET-ALD to ALD. And this is actually independent of age, sex, and liver stiffness. And you see the stepwise increase in cumulative incidence of major adverse liver events, MASLD, MET-ALD, and ALD. Now, this was a recent study, a Swedish cohort study from Hans Hagström's group, including over 6,000 patients with confirmed or presumed MASLD. They then, as standard of care, measured PEth levels, and about 66% had true MASLD. About 20% had PEth levels in the range of that 35 to 210 or MET-ALD, and about 14% had ALD. And what you can see in the first bar here is that those that had alcohol-related liver disease as defined by the PEth score had increased major adverse liver events. And quantitatively, you can see as the PEth value increases, there is an increased risk of MALOS. And this is in patients without cirrhosis. So PEth is really going to be helpful in helping us distinguish these subgroups in conjunction with self-report. As Jessica had said, PEth measures your alcohol consumption in the past 3 weeks, 4 weeks. But what is your consumption over the past year? Are you a binge drinker? Are you kind of steady state? Have you decreased recently, and so the PEth will falsely be low? So we need to take self-report plus PEth when we determine risk of alcohol use. So how does alcohol affect cardiometabolic risk factors? We talk a lot about alcohol on top of MASLD, but how much does alcohol actually cause the metabolic risk factors? So what is the impact of alcohol on type 2 diabetes and obesity? There's actually quite a bit of mixed data of these studies because they don't really reconcile the fact that people who may have quit alcohol recently did it because of health reasons, so they're categorized as not drinking and they appear less healthy, while the people who are drinking then seem relatively healthier. So by leveraging a technique called Mendelian randomization allows you to assess causal effects of alcohol consumption and outcomes without randomized controlled trials. In such a study, among individuals having more than 14 drinks per week, a 1 drink per week increase was associated with an 8% increased risk of obesity, 10% increased risk of type 2 diabetes. That risk for obesity was greater in women than in men, and there was no protective effect of like this mild, less than 7 drinks per week, which often is talked about. Now, what about the impact of alcohol on hypertension? So if you look on the top graph, that's all participants, a systematic review and meta-analysis looking at the dose response of hypertension according to alcohol consumption. Increasing alcohol consumption is positively and almost linearly associated with new onset hypertension overall. If you divide out by sex, for men, the risk increases but tends to level off at higher levels. So you just kind of have that plateauing effect. In women, however, the risk rises more sharply at higher intake levels with a steeper dose response, so that excess hypertension risk becomes only evident above about a drink per day, and you can see kind of all of a sudden that shoots up. So low alcohol intake may increase the risk of hypertension in men, but not women. Moderate to high increased hypertension risk for both men and women. So if your patient says, if I stop drinking, will my hypertension improve? Meta-analyses and large cohort analyses demonstrate that, in fact, there's a dose-dependent relationship between alcohol reduction and blood pressure improvement, the greatest effects in those with higher baseline intake. Reducing alcohol intake by 50% in heavy drinkers, those that are drinking more than 6 drinks per day, resulted in a mean systolic and diastolic blood pressure reduction of about 5 and 4 millimeters of mercury. So reductions were minimal or non-significant in those who were drinking less than 2 drinks, though depending on other risk factors of the individual, it could be impactful. So the American Heart Association, American College of Cardiology in 2025 recommends that the risk of incident hypertension is lowest among those who abstain from alcohol. So what about alcohol effects on cardiovascular risk? In a population-based study of about 6,000 adults in Switzerland, you see the alcohol consumption drinks per week on the bottom panel, and you can see that that systolic blood pressure goes up after you're about that 14 drinks per week mark. As well as the 10-year CAD risk increases and HDL increases over time. When you look at the HDL, triglycerides, and total cholesterol, and you look at binge drinking, you can just see that there's increased HDL with increasing alcohol consumption, total cholesterol, and triglycerides. So as you look along the bottom, you have basic, low levels of drinking, and on the y-axis, you have increasing number of cardiometabolic risk factors. So certainly, as your alcohol consumption increases and as your cardiometabolic risks increase, then your risk for significant fibrosis increases. The risk factors that were associated with a liver stiffness greater than 8, in addition to alcohol consumption, were really diabetes and obesity. You can see that dyslipidemia didn't really play a significant factor, so perhaps we have to think about risk factors differently. So is dyslipidemia as important of a risk factor in MET-ALD as is diabetes, obesity, and potentially hypertension? So this is a slide that Jessica shared with me last night to kind of tee up her conversation. So when we think about these patients along the spectrum, the conversation of GLP-1s already came up, and whether that could be a therapeutic approach in patients who have both disorders, the caveat being the sarcopenia, which we need to be mindful of in patients who have alcohol use as well as cirrhosis. And so that's something that 1.5 grams per day of protein resistance training is absolutely critical. The GLP-1 effect on muscle, I'll just make a comment. We're really learning more about that. I think that it is definitely something to be concerned about in patients with sarcopenia, but I think there's a lot of ongoing studies to see what is the true impact of GLP-1 on muscle mass versus function. So there's steatosis in the muscle. So if you have weight loss, you will lose the fat in the muscle also. So if you were to just look at mass, it may decrease, but we need to accompany that with things like hand grip strength and really tease this out, function versus mass. So I think a lot to come on that. But then, of course, you're going to be assessing patients for alcohol use disorder, and Jessica is going to share with us the best way to approach that. So early here, you're targeting more the metabolic risk factors with the therapies that we talked about yesterday, and as you move forward, you're adding on therapies for alcohol use. So in terms of the abstracts that were presented at the liver meeting related to this, so this is just putting a pin on the idea that even modest alcohol consumption has a role in fibrosis. This is a study from Ajay Desagu's group in India, 7,000 patients, and what they looked at is they looked at both liver stiffness and the FAST score. So in the middle column, a FAST of less than 0.35 is a low risk of significant fibrosis, and you have alcohol consumption on the bottom. So if you look at the two upper panels, which is just liver stiffness, you can see that as you move towards increasing alcohol consumption, you have an increased risk of fibrosis, even as little as 12 grams per day. On the FAST score, it's the reverse because you're moving to a higher risk category if your FAST score goes up. So even modest alcohol can negatively impact liver stiffness in patients with MASLD. So this is a retrospective cohort study of 350,000 adults without known cirrhosis who answered a survey. This is in Denmark. This was a as you know, it's a tax-funded universal health system with a nationwide registry of diagnosis, prescriptions, and deaths. This cohort was established between 2010 to 2017, and there was 3.3 million person years follow-up. And then they looked at 2022. At that time, there were about 35,000 deaths and 1,200 cases of cirrhosis. The largest number of cirrhosis cases occurred among participants consuming fewer than 29 drinks per week, and diabetes increased the 10-year risk of cirrhosis by 4-fold. BMI greater than 30, hypertension, dyslipidemia, and smoking increased the risk by 2 to 3-fold. But this is really where it gets interesting. So if you start to get to the point where you're drinking more than 28 drinks per week, the influence of cardiometabolic risk factors starts to get weakened. So if we use BMI as an example here in the graph, so you have the bands of drinks per week, 1 to 14, 15 to 28, 29 to 42, and then greater than 42, and you have increasing BMI on the bottom. So if you take the first band, as your BMI increases in that drinking level, you have an increased risk of incident cirrhosis. Same holds true if you're drinking between 15 to 28 drinks per week in the green. You see that there's an increased impact of BMI on incident cirrhosis if you're drinking at that level. Once you get to 29 drinks or higher, it's basically flat. So at that point, the cardiometabolic risk factor, in this case BMI, is not further contributing to your risk of incident cirrhosis. It's largely being driven by alcohol. So the effect of BMI on cirrhosis was absent for alcohol consumption greater than 28 drinks per week, and that contribution of alcohol superseded cardiometabolic risk factors in general in development of cirrhosis. So this next study looked at alcohol use after bariatric surgery and the risk of fibrosis progression. It was a single-center retrospective biopsy study in 455 patients. They had either sleeve gastrectomy or Roux-en-Y bypass, and there was a follow-up period of 7.5 years. They looked at increasing FIB-4 post-surgery, and they saw that in multivariable analysis, that increase in FIB-4 was associated with increase in audit C score, increase in age, and there was a protective effect of a decrease in BMI. In women in particular, as they increased their audit C score, there was an increase in the hazard ratio of developing fibrosis progression as assessed by increasing FIB-4. And in men, there was a smaller effect per point, a hazard ratio of 1.07, but there was a risk threshold where after 3-point increase, you kind of leveled off at a hazard ratio of 2.76. So increase in audit C after bariatric surgery is associated with liver fibrosis progression. Longitudinal screening for alcohol use after bariatric surgery is very important, and we need to do that, and women may be at particularly high risk. So this next abstract is looking at premature mortality across the SLD spectrum, and looking at the Enns-Haynes data set from 1988 to 1994, and then 99 to 2014, with follow-up through 2023. They used a survey-weighted Cox model to look at premature death, which they defined as for men less than age 75 and women less than 80, and then they looked at population attributable risks for both metabolic and behavioral factors. So in the first panel, when you see, the other important thing is they corrected for suspected alcohol underreporting. So there's been this big paradox when you look at prevalence studies and you look at what's the prevalence of ALD, everybody's like, what? It's only 1%? That doesn't make sense because of this underreporting. So what they did was they did an adjustment that looked at corrected to match US per capita ethanol consumption. And so when you look here at the prevalence of MASLD, MET-ALD, and ALD in this cohort of 12,000 patients, you can see that with the adjustment of the alcohol underreporting in green, now you see higher prevalence of MET-ALD and ALD, and then obviously in the red without that adjustment. So when you look at age-standardized premature mortality rates, it was greatest in ALD, then followed by MET-ALD and MASLD. And the key drivers of premature mortality was binge drinking with a population attributable risk of 71 to 92%, and in patients with MASLD, it was diabetes that was the main driver. So when you look at kind of the combined effect of diabetes and hypertension across this group, you can see in the first panel, the darkest green, when you have both diabetes and hypertension, that group had the highest mortality among the MET ALD drinkers. And then when you look at binge drinking, and you looked at that interaction with diabetes, those who, if you're diabetic and you binge drink, you're in the biggest kind of trouble with the highest mortality. So alcohol correction reconciles the prevalence and mortality paradox of ALD. Nearly all ALD cases coexist with metabolic dysfunction. So this is actually an important point. I mean, how many have pure ALD? I mean, if 95% of patients who have alcohol-related liver disease have a metabolic dysfunction, one of the risk factors, really we're talking about perhaps not a distinct entity, but really a continuum. And it's dynamic. People are going to fluctuate. So if one of your risk factors was hypertension, you quit drinking, now you have one less metabolic risk factor. So I think this is where we're going to have to be thinking a little bit more about this MET ALD. So yesterday we talked a lot about FIB4, VCTE, the algorithms. So how well does that standard screening algorithm perform for MET ALD? This was a retrospective cohort of 764 patients, of whom 244 had liver biopsies. And the primary outcome was the proportion of patients with biopsy-proven F3 fibrosis who would have missed on having a low FIB4 and a low VCTE less than 8 kPa. And you can see that in both panels. I'll just focus on MET ALD for the purposes of this discussion. So you can see on the top in the first stage, the FIB4, about 56% were low risk. And then if you take that over, 17 or 42% of those were low risk by VCTE or had a kPa less than 8. Of those people, about 5 to 6% had F3 fibrosis on biopsy. So it's just showing that there is a false negative rate, though it's not tremendously high. When you look at the area under of the curve, FIB4 yielded a 0.736 for F3 fibrosis, but they found that the optimal cutoff point was a little bit lower, lower in the age over 65 of 1.65. So when you apply that 1.65 over age 65, which traditionally we use a 2.0 cutoff with MASLD, but they're suggesting that dropping that down to 1.65 in those over 65 with MET ALD will lower that false negative rate from 5.7% to 2%, and the referral rate increase, but I don't think that that's important. So standard non-invasive pathways combining FIB4 and VCTE had a low false negative rate. In patients with MET ALD over age 55, maybe lowering that FIB4 threshold to 1.65 may improve early detection of advanced fibrosis in MET ALD. So the key takeaways: alcohol has a differential impact on cardiometabolic risk factors. Most clear dose-dependent impact in hypertension and hypertriglyceridemia. Mendelian randomization suggests mild causal relationship with obesity and type 2 diabetes. Cardiometabolic risk factors for advanced fibrosis in those with MET ALD. Clear increased risk with diabetes, obesity, and hypertension, and thus should be prioritized, and maybe dyslipidemia is not as important. Both self-report and PET levels are needed to accurately classify MET ALD. Patient reluctance, stigma, even small alcohol consumption can increase fibrosis risk. The contribution of alcohol at greater than 28 drinks per week supersedes cardiometabolic risk factors. So once you get above this level of alcohol, BMI doesn't matter. Longitudinal screening for alcohol use after bariatric surgery is critical. Women with post-surgery increase in audit C may be an especially high-risk group. For those with MET ALD and ALD binge drinking, that accounted for 71 to 92% of the population attributable risk for premature mortality, and in diabetes, for MASLD, that was diabetes with 15 to 19%. And in patients with MET ALD over age 65, lowering the FIB4 threshold to 1.65 may improve early detection of advanced fibrosis in MET ALD. These are our acknowledgments to Tazal and all of the organizers, and Drs. Siddiqui, Lee, and Mellinger. Thank you.
Thank you for your speech. We can take 2 questions, if it's possible. first from me. When we look at the definition of met-ALD, there is alcohol ranges for females and males. Why there is an upper limit? Why there is an upper limit for?
Well, then it's more
in the definitions?
ALD. They're kind of saying that it's ALD predominant then. So the way they got it, it's like MASL predominant, ALD predominant.
Yeah.
So that's really
For
why
the
that
upper
is.
limit.
But I think we need to rethink that in that is it all just met ALD, right? And you just have low drinking and kind of along that continuum.
Thank you.
Yeah.
Yes, Ramazan.
Yeah, thank you, Mina. I followed this question. I mean, the obese patient came to our clinic, and when we asked them about the alcohol use, and they are saying this is the terminology of Turkey. They are most common use. I am social drinker.
Yeah.
I mean, we can use the self-report or we can use the PET values because we do not use the PET value in clinical practice in Turkey. What do you think about the use of this PET value?
Well, so people do underreport, so you have to assume that already. I mean, Jessica had mentioned the time look back is probably the best, but it's quite labor intensive. I mean, the audit C, you can do the shorter 3-question one and then trigger to a longer one. But the reality is that if you're trying to investigate the cause of the liver disease in the patient, and you want to work with them to say, I need to see to what extent is this contributing to that liver disease so I can best guide you and care for you. PET is not available in Turkey, is that what you're saying? It's not available? But should you? I think that you should probably think about starting to do that because it's quantitative, and even if it's about harm reduction, right? It's not necessarily about abstinence. You can use that PET value to encourage your patient that, oh, you're doing better, like your PET is improving. So I think we need to use it as a tool and not as a stigmatizing thing. I try to make it standard of care and order it in all patients so that I don't have any implicit bias in why I'm ordering it in one versus another. Like, is there more trust in one? Like, they're saying the same thing, I'm a social drinker, but why am I choosing to draw PET in one versus the other? So if you make it standard of care, you eliminate that from the equation.
And there's another thing that they always say, I can stop whenever I want.
Right.
So that's another thing. I mean, it's very typical in Turkey. I mean, so I'm not addicted. I'd like to get your opinion. There's a debate about alcohol is like smoking. There is nothing like drinking less. I mean, you smoke, you have damage, you take alcohol, it damages your liver. What's your opinion on this topic? I mean, let's say a person does not have any cardiometabolic risks, is a skinny person.
Weren't we talking about this at dinner
Yeah,
last
doesn't
night
have
when we were drinking?
diabetes, is a nice guy. I mean, he's drinking social. I mean, do you still believe that that person should stop alcohol?
So I think Jessica and I may have a different opinion here. So I think, and I kind of showed that by my fibrosers, if you're not a fibroser, okay, so you don't have any fibrosis at all. Am I really correct? Now, other causes of, cancers, extrahepatic cancers, it's a carcinogen. We can have all of that. Surgeon General has declared it. So, but I'm just focusing on the liver disease for a moment. If you have zero fibrosis, and it's an important part of your quality of life, I tell them, I'm monitoring you. If it's a problem, I'm gonna let you know. But I'm watching you, we have an open dialogue, and we talk about it. And if they want to reduce, if they don't want to reduce it, right? If they feel, and if they don't have any fibrosis, I think it's a risk-benefit ratio, shared decision-making with the patient.
Yes.
So, by the way, I want to say something. I'm currently working in Germany, and it's about peer drinking. Anytime when students are coming to me, we are talking about that issue, and the youth seeing the alcohol use other than this population, I think, they are very concerned about the peer drinking, and they don't think anymore. I just want to say this, but my question is something different. How is your clinical approach with incretin analogs to meta-ALD patients? We just talk about ALD and muscle D. How is your clinical practice?
So if I am treating say they have diabetes or they're living with obesity, and they happen to have alcohol consumption above what they should have, then the GLP-1 is a great place to start, but you're treating the metabolic disorders. You're treating the obesity, you're treating the diabetes, and you're very clear on that. If a side benefit of that is that they also decrease alcohol, then it's a win-win. But right now, you can't treat for alcohol with a GLP-1. You're treating the metabolic risk factors. And then, of course, it's the monitoring. Just like with alcohol, it's even more so, but even MASLD, we do educate a lot about muscle and protein intake and exercise. Did that answer your question? Yeah.
Thank you, Mina. Now I'm recalling Jessica to the stage to give the second lecture. It is about Hepatology's Guide to Alcohol Use Disorder. So we are in the game.
There we go. All right, so I'm back. So now we get to have a really uncomfortable conversation about alcohol. No, I'm kidding. Yeah, when you're the alcohol researcher in the group, it's always really uncomfortable at parties, right? People look at you and they're like, is this too much? Am I drinking too much? Asking for a friend. So I want to start off with just some core concepts when I think about alcohol use, alcohol treatment. There's alcohol as measured by quantity frequency measures, okay? So this is a lot of what we talk about when we talk about high-risk drinking, right? How much is someone drinking, right? 4 drinks a day, 2 drinks a day. Met-ALD is all about just amount. It's not about anything else. The audit, C, is largely about amount. And then there is this alcohol use disorder, right? If you look at the diagnostic criteria of an alcohol use disorder, there is no mention of amount. There's no amount of alcohol that you have to be drinking to get a diagnosis of an alcohol use disorder, right? In AUD is all about how is the alcohol use that you are drinking at whatever level impacting your life. So socially, at work, in your relationships, are you developing tolerance? So you drink more and more to get the same effect? Do you have withdrawal, et cetera? So I just want to set the standard that those two things are two different things. And you can absolutely have patients who are drinking very heavily, but they do not have an alcohol use disorder. I see that rarely in my clinic. I tend to get a much more severe form in my clinic. I'm a little biased that way. But you will absolutely see patients who might even be drinking like a pint a day. That's 10 standard drinks per day, who don't meet criteria for an alcohol use disorder and who are able to stop without alcohol treatment. So I'll talk about management, talk about treatment, but understand that these two concepts of the quantity, frequency, and then how it affects your life are different concepts that often coincide but don't always. So this was a great graphic by my colleague, Scott Winder, who has been a colleague now for over 10 years and works with me in the ALD clinic. He is a psychiatrist, transplant psychiatrist, addiction psychiatrist, and he recently published this work on alcohol treatment and stigma. And I thought this was a great way of thinking about it, that we have management of the alcohol use disorder, or the alcohol issues, where you're just trying to minimize the sequelae. So this is treating alcohol withdrawal, maybe getting someone a liver transplant, right? That does something about the consequences, but not about the primary problem, which is the alcohol use itself. And then there's treatment in the middle, which is really where we're addressing the disorder itself. We're addressing the disease. And this is really the most successful way of addressing this problem and making a change. So this is where we're looking at substance treatment programs, medications, group psychotherapies, peer support, support programs. You cannot cure an alcohol use disorder typically once someone has an AUD. So those especially moderate to severe AUD, you do often see the symptoms go up and down over a lifetime. They come and they go. And so it's often a chronic disorder, and this is how I present this to my patients. It's like managing diabetes, right? The patients that I worry about are the patients that tell me, I got this, Dr. Mellinger. I can't imagine that I would ever drink again, right? I believe them. I believe that they cannot imagine that they would ever drink again, and yet so many of my patients will, because they misestimate their risk. They don't estimate their own risk of drinking correctly. They think if they can go into a bar, that's good. I can go into a bar and not drink, right? And they think that that's a protective mechanism when you and I are all sitting there going, no, don't, if you've got an alcohol use disorder, you shouldn't be in a bar, but they think about it very differently. So when I think about management and treatment of ALD and AUD, I think about it kind of by stage. I am a hepatologist, so I want to stage that fibrosis as one of the commentators talked about. We definitely want to know where are our patients on this fibrosis stage, right? If they're kind of earlier stage steatosis, steatohepatitis, early fibrosis, under F3, like I as a hepatologist, I often don't really need to see them in the clinic because there's not a lot that I'm doing. And so I reserve myself for more advanced liver disease. So in our ALD clinic, referral criteria are advanced liver disease. It has to be cirrhosis, it has to be acute ALCAP. And then with the AUD stage, again, I also think the same thing. There's a staging to how we're thinking about treating this. More severe alcohol use disorder, inability to stop that heavy drinking, then I want to start thinking about referring people to treatment, starting alcohol relapse medications. Often these go hand in hand. Again, if you're in the orange or the red, you're often in the orange or the red in all those categories, but not always. You don't always see them together. So there is a pretty high prevalence of ALD when you do diagnose an alcohol use disorder. So we're starting to see people kind of reverse this a little bit, where they're going into the alcohol use disorder population and looking for ALD. So instead of waiting for them to come to us in our multidisciplinary clinic, starting to go out and find them in the alcohol use world. So if you're looking at all subtypes of ALD, all stages, and you have an alcohol use disorder, over half of these patients with even a mild AUD will have ALD, right? You get into your heavier uses of alcohol use disorder, again, about 13% of those folks will have cirrhosis, high-grade fibrosis. So it's pretty darn common. And the mortality goes up, as, again, we all expect with increasing amounts of alcohol use. And much of that mortality from drinking is attributable to liver disease and its consequences. So ALD is actually a very high component of the mortality of AUD. So why do we want to treat it? It's because alcohol use in a dose-dependent fashion increases risk of developing incident cirrhosis more in women than in men. And we can talk about these sex-specific differences. This isn't the focus of this, but there's definitely sex-specific physiologic reasons why women experience faster development of advanced liver disease. It's called telescoping. So they fly through the compensated cirrhosis phase and they go to decompensated cirrhosis much faster. Early in my research career, when I was a junior faculty and before I could hire people to do this for me, I did all my own ascertainment for my studies. I found my own patients. Oh, it was hard to find female compensated cirrhotics. They just flew through that stage, you couldn't find them. And so they kind of telescope through that in a faster fashion. And what helps these patients survive? It's stopping drinking. There is nothing that we do that is as powerful as to help these patients live longer as stopping drinking. The only other thing that's as powerful is taking out their liver and putting in a new one. And in that case, you also have to help them stop drinking. So kind of all roads sort of lead through helping these folks stop drinking. And early treatment, connecting patients to treatment, actually improves outcomes. So this was a great study out of, I believe, Mayo, where they looked at attendance at alcohol rehab in the first 30 days after you had that first admission for acute ALCAP. And what they found was that readmissions were lower and mortality was lower for patients who had attended alcohol treatment. The other thing they found was that not very many patients did. So many patients didn't go, couldn't get in, or refused to go. Only about 1 in 5 got into alcohol treatment. Remember, these are patients who have extremely high mortality from acute ALCAT because of it. So multidisciplinary integrated management has become really kind of the watchword here for how we treat patients with ALD. And that just means putting it together, right? Putting together the alcohol treatment with the hepatology management, ideally at one place if you can co-locate it, but integrated care is a spectrum. So this is a slide that my colleague Scott Winder has put together, and we talk about this all the time, right? So we are able to have a co-located clinic. I'm very lucky I have a psychiatrist right at my elbow to help me with this stuff. That isn't always possible in every system. And so there are lots of things that folks can do, from just asking about alcohol use and then counseling patients very briefly, 5-10 minutes about their alcohol use. That's integrated care. If you're doing an audit C, you're asking about it, and then you're doing something about it, referring to treatment, that is integrated care at that most basic level, and then it goes on from there. So, and this is one of my favorite studies on top here. It was a blinded study of audit C and asking patients about alcohol use. So in a post-transplant clinic, they asked patients about, did they drink? The hepatologist asked them if they drank. They gave them an audit, and then they had the addiction specialist ask them about alcohol use. And the audit C alone, 3 questions, takes about 30 seconds, picked up about 15% more people who were drinking than just the hepatologist asking alone. And then the addiction specialist got about 5% more. So we can ask, but using those surveys like Audit C can really help. Again, using alcohol biomarkers, whatever you have access to, whether it's the urinary ethyl gluc, the PEth, this data here that you see on the alcohol biomarkers, the statistical correlates, this is all from liver disease patients. So all these numbers and the statistical performance comes from studies in patients who have cirrhosis, in patients who have ALD. So they perform quite well, and we really should be using them. There's going to be consequences, though, when you use them. So when you use PEth, you will find more people who are drinking when they told you that they weren't. So this was done at Henry Ford at my current institution, and essentially what they found was that when they started to use PEth, they were delisting people more frequently because they found more drinking that they didn't know was going on. And so you really want to be using this in conjunction with a clinical interview. You never want to delist someone, at least in the US, just off of a PEth. You have to talk to them and find out what's going on. It's actually a medical legal issue. We can get sued if we take somebody off of the list on the basis of a PEth only, on the basis of a lab. So in terms of alcohol treatment, what exactly is out there? So there's a lot of different stuff that you can do. The most basic level is the screening, so looking for alcohol, doing a brief intervention. That's just brief counseling, like brief kind of bedside counseling, 5-10 minutes, and then referring to treatment. This is called SBIRT. There is a host of literature in the alcohol world that this works, largely for the lesser, less severe forms of alcohol use. So an SBIRT typically is effective, but only really if you're in kind of that lower level of alcohol use or the milder alcohol use disorders. When you start getting into moderate to severe alcohol use disorders, heavier alcohol use, you really have to go for referrals to treatment, use of medications. That tends to be more effective. So some pharmacotherapy options for AUD treatment. Obviously, disulfiram is FDA approved in the United States for it. I have never used this in liver disease. It is hepatotoxic. I have seen patients need liver transplant because they were put on this medication, so I have never used it. It's contraindicated in liver disease patients. Naltrexone, acamprosate are the 2 other FDA-approved medications. Lots of great data for these for alcohol cessation. So the number needed to treat in meta-analyses for alcohol cessation for naltrexone and acamprosate is about 22 for naltrexone and about 26 for acamprosate, right? So statins for preventing a first cardiovascular incident is about 50. So these things work, we just don't use them, right? They work, and the data is largely, almost exclusively in the non-liver disease population, but they are effective, and multiple meta-analyses have shown this. The non-FDA approved medications, so these are off-label usage that we often turn to. Gabapentin is one that we turn to quite a bit in my clinic. Topiramate has some effect on alcohol craving, also is approved for obesity. So sometimes we will use this occasionally for patients who have obesity issues, need to lose weight, and need alcohol use help. Got to be careful with that in cirrhosis because it can cause neurologic side effects. And then baclofen is the only one that has, I believe now, 2 randomized trials in liver disease patients that did show effectiveness, but it still remains off-label for alcohol use. So does this work? So again, we have an absolute dearth and a giant need for randomized prospective trials in our population, our ALD population for these. So everything I'm going to show you right now is retrospective observational association only. So pharmacotherapy does appear to be associated with increased time to decompensation and reduced odds of developing ALD to begin with, also with reduced odds of decompensation. This was in a Veterans Administration cohort, so this is like a single payer system, more in line with kind of what we see outside of the United States in terms of the healthcare delivery. And they found reduced mortality for ALD patients who had a prescription for a medication for alcohol use disorder. Psychotherapy, again, also you see reductions in incident ALD and decompensation if you have compensated cirrhosis at the beginning of this. So kind of the story remains the same. When we looked at our own integrated ALD clinic where we put the 2 things together, alcohol treatment and hepatology care at the same site, same time, co-located, we found in a retrospective study of our own clinic that we had reductions in alcohol use and reductions in ER and hospital utilization. The typical usage in the population of ALD patients for medications is about 1%. So about 1 to 2% of patients with ALD will get a relapse prevention medication. Really, really low. In our clinic, by co-locating and integrating the care, 60% got treatment, got medications, and 100% got behavioral care. The late Mo Sengupta at Cleveland Clinic started an integrated care clinic as well, modeled on ours in Michigan, and found very similar outcomes as well in terms of reduced alcohol use, reduced admissions as well. And we're finally now, over the course of my 15-year career or so, we're seeing enough integrated care data, enough that we can begin to meta-analyze this. So again, it's not huge numbers of studies, but enough that we can start to kind of lump this all together and look at the performance of some of these interventions. And what we're finding is that outside the liver transplant setting, when you have integrated care, you do see reductions in drinking. No significant findings on mortality here, but reductions in readmissions, reductions in decompensation. In the liver transplant cohort, however, you do see reductions in mortality. So patients stay alive longer in the liver if they've had a liver transplant, if you have integrated care, in particular co-located care. Why is this? So this is kind of my thoughts on why this might be. So patients don't want to go to alcohol treatment, and I could do an hour-long talk about why that is. That's been the kind of other piece of my research, is figuring out why don't people want to go? What is this all about? But it makes it easier to go if they're coming to see you and they see, a psychiatrist, they see a mental health professional. You should probably warn them that they're going to see a psychiatrist. Nobody likes ambush psychiatry, right? Like, surprise, you're going to have a psychiatrist see you. So do warn them ahead of time they're going to do that, but it does make it easier for them. It also destigmatizes it, and it sends the clear message that alcohol treatment is part of their medical care. This is not something different. This is not something special. This is not something they have to go off to an addiction treatment to get, or optional. This is the critical thing that is going to reduce their mortality and keep them alive. So if we do it at the same time, same place, it sends a powerful message, right? They will listen to you as a hepatologist about their alcohol use more than they will listen to a psychiatrist. And I've seen this repeatedly. They trust you. They trust you as their medical doctor. So if you talk to them about this and make it clear in a destigmatizing way, get their trust that this is critical for their medical treatment, they will listen. They really do. It capitalizes on those relationships of trust, and it leverages their care about the liver. They care about their liver disease, and it leverages that to say, look, we're going to give you the best evidence-based treatment is this. It's getting to alcohol cessation. And this is just yet another meta-analysis that looked at co-located care. So in the integrated care space, as I said, there's kind of variation. You can do it where it's not in the same space, because a lot of people don't have it in the same space, and that's fine. Or you can do it like same place, same time. And this was co-located, same place, same time care that they looked at, and they found that it was improved. Again, field is kind of hampered by not a lot of studies here, and so I think this is, however, a key part of the NIH's focus. So there's potentially going to be some restructuring of NIH. Not sure if that's actually going to come to pass, but regardless, in their executive summary, integrated care for alcohol-related liver disease is a key feature of the focus of what the NIH and the behavioral health movement wants to do. So they recognize how much this is important. I'm going to jump to this one just for the space of time. Integrated care can be really simple, right? So you can do a fibroscan on somebody, as this showed, and give them some biofeedback about their liver disease. That was it. That was all they did in this study, and it produced increased amounts of abstinence in the population who had the fibroscan and had that biofeedback. That is about as light touch as you get, right? The only thing lighter touch was this one, where they just did an audit C. Same exact principle. They did an audit C. They did a kind of a liver stoplight, sort of like a FIB-4, you know, are you high fibrosis or not? That's all they did. They gave them that feedback in a primary care clinic, and a year later, they had substantial, significant reductions in their audit C scores and their alcohol use. Again, when we integrate this stuff, even at the most basic level, it really has an impact. So to that end, we've been reconceptualizing how we think about the care of these patients. Patients around the time of transplant who have ALD, they get a ton of care, right? They get to see social work, they get to see psychology, they get to see psychiatry, they get to see all these people. But what we want to do is start expanding that upstream and downstream. I'll talk a little bit more about some of the controversies in transplant, and especially short sobriety transplant, but I love this paper so much. I saw the abstract a couple of years ago at ASLD, and I was looking for this paper because this is so great. So there are 3 lines here, not 2. And what they did here was they took a post-transplant population and they measured who had never relapsed, who had relapsed, and then who had relapsed and gotten back to abstinence. The green line are people who relapsed and never got back to abstinence. The line that looks purple to you is actually the blue and the red. It is people who never relapsed and people who got back to abstinence after relapsing. And what it means is that if you get back to abstinence after relapsing, your survival is absolutely identical as if you never relapsed at all. So to me, this was a game changer, right? What it told me was maybe we shouldn't focus so much on who's high risk and trying to figure out who's going to relapse, because if you're 31 and you're getting transplanted for acute ALCAP, odds are in the next 30 to 40 years, you're probably going to have a drink of alcohol at some point. So let's focus instead downstream here in this post-transplant period and expand our thinking about how to manage these patients from just this little narrow band of blue around the time of transplant upstream to find them earlier, and downstream to manage them post-transplant, so that if and when they do relapse, as many will, we can get them back to abstinence and keep them alive, right? That's the point. It's not the end of the world if somebody relapses. It's treatable, right? It's treatable. People get cancer after transplant and we treat it. We don't go, oh no, sorry. We go and we treat it and we keep them alive. So to that end, this is just a quick slide about what we've been doing in Ford. So we started our clinic at University of Michigan, one site, and then we moved everything last August to Henry Ford in Detroit, and have now expanded our integrated co-located clinic throughout the state of Michigan. So about 10 million patients in Michigan. Henry Ford Health takes care of about half of them. So roughly 4 to 5 million fall under the umbrella of Henry Ford Health for Care. And so we moved our clinic over there and now have about 5 different sites of that clinic where I travel and drive and go to all these sites along with Dr. Winder. Sometimes we carpool. He has a nice truck, so I get to ride in it. It's very great. But we've been able to expand this out to the state to really make integrated care something that people can access in the US, at least in the state of Michigan, because it's tough for our patients to get there. And we also offer virtual care to really kind of send home the message that this is really critical and to start delivering it. I put a lot of miles on my car, but it's okay. I really like it. So with that, I'll take questions. Thanks.
It's a brilliant talk. I think the most important thing is a case finding study. So people don't want to declare they are drinkers in my country, for example, because they have private insurance and they will be, not covered by the insurance if they are recorded. But even though the management could be a Pyrrhic victory. So how about people using recreational drugs and alcohol together and have metabolic syndrome as well?
Yeah.
Is the management rather difficult and the outcome not really brilliant?
Yeah. The short answer is yes, the management is more difficult. So generally, and we see this pretty frequently, the comorbid substance use disorder rate in our ALD clinic is about 85%. So about 85%, 80 to 85% of our patients that we see in that clinic have another substance use disorder besides alcohol. So they also, about 80% of them have another mental health disorder like depression, anxiety, bipolar, eating disorders, et cetera. So they are very complicated. And this is where working with our mental health folks is really critical, right? I am not an addiction specialist. So if we get to that level of complexity where people have comorbid opioid use disorders, tobacco use disorders, this is where we really need to be closely working with our mental health colleagues to adequately treat them. Because if we don't, what winds up happening is they just don't get treated, right? I'm too afraid as a hepatologist to try to treat their depression and their opioid use disorder along with their alcohol use. My psychiatry colleagues are scared about their MELD being 16 and having cirrhosis, so they don't want to prescribe anything. So they fall in the cracks and they just don't get treated. And so the key is to really start working with our addiction colleagues to identify this, and then if they're in your clinic, great. If they're remote, that's fine too, to really try to help patients get treatment, and then to prioritize, and this is the shared decision making Dr. Bansal was talking about, what's most important to my patient, right? If their opioid use disorder is the most disruptive thing in their life right now, that may be what we focus on. We focus on getting them, on Suboxone, on some type of treatment, and then work from there. And oftentimes that harm reduction approach where I'm not even talking about the alcohol use, but I'm focusing on something else that they care about, it produces reduced alcohol use. We didn't talk about harm reduction, again, could do a whole hour-long talk about that, but that does produce reductions in alcohol use when we do that.
Thank you.
Yeah.
Dr. Kim.
Thank you, Dr. Mellinger. I hope the audience agree that there's only one Jessica Mellinger in the world.
Thanks.
Special. Dr. Bansal mentioned this, there's a biological spectrum.
Yeah.
And for the case that we just talked about, the kind of scenario where you have a multi-dependency going on, you definitely need multidisciplinary care.
Yeah.
But there are many situations where you don't have access to your SCOT, right? So
Exactly.
you're on your own, you're seeing an ALD patient, and you feel like you need to do something, and you mentioned 5-minute brief intervention counts, and that won't work for everybody, but there's a spectrum of people where you can, it would work. So what does it look like?
Yeah.
And for people who are interested in learning more about it, what can they do?
Absolutely, great question. So the brief intervention that I spoke about is often based upon the principles of motivational interviewing. So when I got into this work the last time I had heard about motivational interviewing was in medical school, when you had a lot of time to go and sit with patients, right? And you don't have as much time. But the principle is to be very respectful of the patient and kind of ask, right? Like, may I share some information with you about alcohol use? May I share some information with you about, obesity, about your weight, et cetera. And then to work with the patient to develop their own sort of motivation for change. So you might ask them, like, what do you think is the biggest block? What do you think is the thing that, is the most, difficult for you with respect to alcohol use? What drives you to drink? What's a trigger? They know, they'll tell you. Often for me, it's insomnia, pain, anxiety. Those are kind of 3 biggies. And those are things I can do something about, right? So I can treat their insomnia, and I do. I can treat their anxiety, and I do. I can treat their pain, and I do. And that can help them. So I think just that brief kind of connection with them, using those motivational interviewing principles, open-ended questions, reflective listening. So what I hear you say is that this is really hard for you because everybody around you drinks. So would you like to brainstorm some ideas about that, et cetera? Like, it's very kind of patient-centered. It requires practice. So if you're interested in learning more about how to do motivational interviewing, there's some great books. The Motivational Interviewing kind of manual by Miller and Rolnick is kind of the one to use to really look at. And then there are online trainings that you can get to kind of practice motivational interviewing. It works for a lot of stuff. It's good for any kind of behavior change that your patient might not be sure that they want to make, right? They might not really want to lose weight. Not sure that they can do it. It's when you're ambivalent, right? When you're not sure you want to make the change, that motivational interviewing and these brief interventions can be really effective.
Very short question.
Yeah.
Can nurses be taught to do that?
Absolutely, yeah. Yeah, nurses can do it, medical assistants can do it. I actually have in one of my NIH trials, we have one of my coordinators who is a bachelor level, was previously a medical assistant, is being trained to give the motivational interviewing and the health coaching. So you absolutely can. We have medical assistants in our clinic, and oftentimes they're eager to do more and eager to help, and this is perfect. The patients will talk to them and to your nurse in a totally different way than they will to you as the MD. They're scared of us, right? They want to make us happy. They don't want us to be mad at them, right, when they see that white coat. So they'll tell me what I want to hear. They will talk in a completely different, often more honest way with our medical assistants and our nurses. So that's a great suggestion, Ray. Mm-hmm. Yes, sir, go ahead.
So, thank you. My question will be about a different drinking pattern. Actually, there's some evidence of non-harmful recidivism after transplant that doesn't affect their prognosis, we know.
Yeah.
But there's also some controversy on this, that there's some triggering point in their brain that they can lose their control.
Yeah.
Is there any discrimination point in your mind or in your daily practice that you use to follow these patients and warn them?
That's a great question. Well, as Dr. Bonsall alluded to, I'm kind of a hammer on this. I'm like, abstinence only. I think we don't know exactly who can tolerate a low level of drinking. The reality is that if patients are drinking a little bit, like kind of every now and again, it's probably not hurting their liver, right? Just like Dr. Bonsall was saying, I can't say that that's like going to be the thing that destroys the graft. What does give me pause is that when patients have drank to the point of needing a transplant because of alcohol use and ALD, they are almost always in that moderate and severe alcohol use disorder category. In that case, the way that I think about it is like, like in a barbecue when you have charcoals, right? Like, I don't know, does anybody do charcoal barbecues anymore? I have no idea if it's all propane. But I'm old enough, I remember the old Weber girls with charcoals, and like lighter fluid. It's like having banked warm coals. They're not lit up, but there's still a little bit of a spark there. And you put lighter fluid on that, they'll come back alive. And so when I talk to my patients about this, that's what I tell them. It's like, yeah, you can play that Russian roulette if you want to. But I always ask them, have you ever been able to control your drinking? Right? Have you ever been able to do that for any length of time? They almost all say no, when they're being honest, right? This actually comes from Alcoholics Anonymous. So the great obsession of every patient who has an alcohol addiction is not alcohol. It's that they will be able to drink normally. Drink like a normal person, right? And the vast majority of them just cannot. Maybe some can, but I don't know who that's going to be. And so I need to message to my patients that you really need to not risk it.
Okay, thank you very much indeed.
Now, we are going to have 2 case presentations at the end of this morning session. The first one is going to be presented by Nilay Danish, and the second one, Zekiye Nur Harput. As moderators, we have decided to get discussion at the end of each presentation without interruption, okay?
Okay, thank you, chairs. And first of all, I appreciate the organizing committee for this opportunity to speak here. My case is 31-year-old male, and he is chemical engineer. He applied to the emergency room 2 weeks ago with the symptoms of seizure and Jordan's. And there was no abdominal pain, no diarrhea, no nausea and vomiting and fever. He was using medications, diazepam, B vitamins, and folic acid. He was drinking regularly, and he was smoking as well. After 5 days of diazepam, acamprosate was prescribed by the psychiatry. His first alcohol use started at age 20. For the last 5 years, he has been consuming a minimum of 35 cl of vodka almost every day. About 3 years ago, he was able to abstain from alcohol for about a month. Afterwards, he continued to use it regularly. He last drank alcohol 2 days ago, and he started drinking alcohol in the morning. 5 days ago, he didn't drink alcohol and had a seizure, like epileptic attack at home in the afternoon. He had also a seizure in the emergency room as well. Diazepam was administered. He had psychiatric referral about 5 months ago, and he was using diazepam and B vitamins and is currently not using psychotropic medication. On current examination, this is the examination notes from psychiatric consultation, and there was postural tremor, time orientation disorder, and mild anxiety. But after 1 day, I saw the patient, his time orientation was complete. So I'm not sure if this was encephalopathy or due to alcohol withdrawal. Oh, sorry. So, according to alcohol withdrawal assessment scoring guidelines, his score was 9, which is compatible with mild alcohol withdrawal syndrome. So, I'm not sure if you can see at the end point of the slide. No, I'm sorry. I'm really sorry. At the bottom of the slide, I can say there is a disorientation of time of the alcohol withdrawal syndrome guidelines. So in his physical examination, he had icteric cycleria and grade 1 ascites on abdominal examination. There was no pathologic finding afterwards. And these are lab levels at admission to AR, and AST and ALT levels were higher and with a ratio more than 2 to 1. His GGT levels and Billy levels were also high, as well as MCOB and INR levels. And you can see he had bistopenia, and his metabolic discrimination function is 28, and blood sodium is 24. His cocaine, amphetamine, opioid, cannabis, and benzodiazepine parameters were negative in urine, but alcohol in plasma was 85. These are the parameters to exclude the other liver diseases. Viral hepatitis serology was compatible with hepatitis B and A vaccination, and his autoimmune parameters were all negative, and quantitative IgA levels were found to be a little bit high. And this is diagnostic paracentesis at admission, and his ascites is compatible with portal hypertensive ascites. There was no spontaneous bacterial peritonitis. The patient presented to the emergency room with a history of seizures and head trauma. So not only abdominal, but also pulmonary and brain and maxillofacial CT scans were taken in the emergency room. Therefore, we didn't have any abdominal ultrasound as an initial examination. In his CT scan, there is no pathological angiographic findings, and there was widespread fluid in the abdominal cavity, and there was hepatosplenomegaly and heterogeneous liver parenchyma. This is the CT scan of the brain. There was no evidence of intracranial hemorrhagia, but there was a hematome in the soft tissue of the right occipitoperitoneal area. So at admission to emergency room, his metabolic discrimination function is 28 and blood sodium is 24. Lactulose, spironolactone, furosemide were prescribed. This is his initial MRI, And the left lobe of the liver is hypertrophied, and the left lobe parenchymal contours are slightly irregular. The right lobe of the liver is enlarged to nearly 19 centimeter. The liver parenchyma was singular heterogeneous, and there was inhomogeneous hepatostatosis. The spleen is also enlarged, and there was widespread free fluid in the upper abdominal region. These are his lab levels after 5 days, and his AST and ALT levels still remain high. However, total bili and direct bili levels increased, and his INR also increasing. So with all these lab levels, his metabolic discrimination factor is 32.4 and MEL sodium is 26. So, in addition to his medications, prednisolone was started. After 7 days, after 7 days of his steroid initiation, his AST and ALT levels remained high. However, his bili levels and INR decreased, and his least score is less than 0.45, and MEL sodium decreased to 22. He is also going to psychiatric follow-up routinely, and he was using SSRIs and acamprosate. Prednisolone was stopped after nearly 2 months. These are his lab levels during the 6 months period, and after prednisolone stopped. As laboratory levels improved, the steroid dose was gradually reduced and then discontinued. It took quite a long time for INR levels and platelet counts to return to normal. Everything was going well until one day the patient came for a checkup looking really pale. You can see the hemoglobin level as 3, and he was walking. He was coming his checkup by walking, but he was looking really pale. And this is true. 3 is true. it's repeated. It's true. So about anemia, his peripheral blood smear and iron parameters were constituted with iron deficiency anemia. And further investigation revealed that the patient had been experiencing melena for several days, and he didn't say anyone. After 4 packs of erythrocyte suspension replacement, an endoscopy was performed, and there was gave in the antrum, and endoscopic plasma coagulation was performed, and there were also varices. His colonoscopy was near normal with some suboptimal limits. 2 days later, after argon plasma coagulation, endoscopic band ligation were performed for the varices. Repeated endoscopies was performed on gaves for argon plasma coagulation and endoscopic band ligation. And propranolol was started after ligation. I can pass it. And this is 1 year later. His MRI scan, the liver is normal size and has smooth contours. Parenchymal density is heterogeneous, especially around the portal area, and there is periportal edema. No focal lesions were detected. Vascular distribution is within normal levels. However, the spleen measures still 16 centimeter and appears homogeneous. This is 2 years lab levels, and 3 years after the alcohol cessation. No erythrocyte suspension replacement was needed, and hemoglobin levels gradually increased. I just gave IV iron for once, and after that, hemoglobin levels were all normal. There are 2 ultrasounds, partially different ultrasound reports written by 2 different abdominal radiologists 8 months apart. And this is the first one. In this ultrasound, the long axis of the right lobe is 16 centimeter. The left lobe appears slightly hypertrophic and has smooth contours. And the portal system is normal. This is the first ultrasound. After 8 months, the second ultrasound and the last one, the liver measures 13 centimeter in long axis. The echo pattern is granular and its echogeneity is heterogeneous. Its contours appear undulating. the left node appears hypertrophic, and the portal vein is 13 millimeter. And a pleural effusion approximately 15 millimeter in diameter was observed on the right side. So afterwards, I performed an endoscopy, and there were still 4 colon varices, but there was no red color sign. If so, I will perform endoscopic butt ligation. GAVE is no longer available. And these are his last medications. Spironolactone and furosemide in reduced doses, lactulose when necessary, and propranolol he is still using because of the varices. And he also regularly attends psychiatric follow-up appointments. Right now, his sodium, MELD sodium is 9, and he has been not drinking for 3 years. Thank you for your attention.
Any question or contribution, comment, short one? Okay.
Thank you, Nilay. It's very nice. But I couldn't understand the ultrasound finding.
Me
In
too.
the 6 months, how does it change?
Yeah.
Are you sure that this man doesn't drink again?
No. I'm checking it from his parents, his brother, and friends, so he's not drinking. I'm sure about that. But 2 different radiologists and 2
Maybe.
different reports.
Unexperienced, the radiologist maybe.
Yeah. Both are good abdominal radiologists. I didn't understand the difference actually, but there's no fluid anymore, and in the abdomen, I mean, the liver and the spleen decreased in size. So these are, I think, good signs. But we will see. Maybe an MRI I would do. I don't know.
Thank you.
Thank you.
Okay, yes, sir.
I'm thrilled by the anemia, which was 3.1.
Yeah.
I mean, it's very
Unbelievable.
curious. Yeah, but still the anemia continues. So what would you think about this severe portal hypertension? Do you think about
Sorry.
something to...
Can I take my slides, please? Can I take slides? There is no anemia anymore. There's
7 point something?
No. Last one, I can say. $15 or something like that. No
15.
anemia. 15. So I'm just confused about the varices with 15 hemoglobin. So I am going on, and he's using his propranolol because of that, because there would be probably a partial hypertension with hemoglobin 15. So I must show it.
Do you think it's true? It's correct?
Yeah, it's cute, because several times you can see here, several times.
That's fine.
Several, 15.
Osman son ve çok kısa soru.
Okay, Nilay, do you have elastography before
not
and
for
after
that,
the treatment?
Not for that patient, but I am planning to perform it in March, and after all the AST, ALT levels were normal. I will do it. Thank you.
Very short answer, please. What is the final diagnosis of this patient?
Alcoholic hepatitis, I thought this is the decompensation of the cirrhosis and alcoholic hepatitis experience. And right now, there is still portal hypertension.
Alcohol-related cirrhosis and alcohol-related
Hepatitis. You are correct. Thank you.
Okay, thank you.
Thank you so much.
Okay. Second presentation.
Kızın ismi ne galiba? Zekiye Nur Harput.
Good morning, everyone. I will present the second case in the session. 40 years male, obese, and 300 gram per week alcohol for 20 years. Non-smoker, has no additional disease, no medication, and he proceeded 2 years ago sleeve gastrectomy, and his family history pancreatic cancer in his ankle, and no family history of liver disease. The patient has some problems after the sleeve gastrectomy. He has some non-specific dyspeptic symptoms, but because of the in the laboratory findings, slightly decreased platelet levels and the elevated liver function test, he was referred to gastroenterology department. In the physical examination, but the BMI index is 29, and before the surgery, 41. Blood pressure slightly elevated, heart rate is normal, he has splenomegaly, and other physical examination findings were normal. In the laboratory findings, slight elevated liver function, 5-4 score, 2.6, and viral serology and autoimmune markers, all negative. And USG has revealed hepatomegaly, hemangioma, splenomegaly, and no esophageal or gastric varices were detected in the GI examination. In the timeline, 2 years ago, he has sleeve gastrectomy, obesity, or muscle, and in 2 years, he weight lost 45 kilograms, and now, due to liver cirrhosis stopped, he referred to gastroenterology department. In the preoperative evaluation in dynamic MRI, says that fatty liver disease, millimetric gallstones, minimal splenomegaly, fatty pancreas, and cyst in the left kidney, and echocardiography, hypertensive cardiomyopathy. In the intraoperative liver biopsy, says that liver fibrosis stage 3. In the final diagnosis, they thought, I guess, they're muscle or obesity just, but we have low platelet count, splenomegaly, slight elevated liver enzymes, obesity, alcohol use disorder, or just heavy drinker. I guess our accurate diagnosis is metal AD, secondary to metal AD, early stage cirrhosis. And the prior surgery, alcohol consumption wasn't assessed or was underestimated for physicians. No counseling or recommendations regarding alcohol use were provided. No preoperative psychiatric consultations or gastroenterology consultations. I have some questions in my mind about the patients. In the first-line treatment, early stage metal AD, sleeve gastrectomy can be considered, or before initiating any treatment metal AD, should a psychiatric evaluation for alcohol use disorder or heavy drinkers recommended? Is any level of alcohol consumption safe, or should complete abstinence be recommended? Maybe after the case we can discuss. And the sleeve, we know sleeve gastrectomy, 45 kilogram in 2 years, but patient still overweight. In the gastroenterology department recent radiologic findings, dynamic MRI is the similar compare from the 2 years. He has hepatomegaly and splenomegaly and the stable lesion with hemangioma. And MRCP is a new 2 millimeter size non-specific benign-looking cyst in the pancreas. They are not connected to the main duct, and I mentioned that he has family history about pancreatic cancer. And the CAP score 274 and 7 kPa. One side, family history of pancreatic cancer, pancreatic steatosis, cholecystolithiasis, and pancreatic cyst, and the other side, overweight person and metal AD. What should we do next? After the lecture, Professor, what do you think about? Stop drinking, diet, exercise, yes, that's okay. But any medical intervention is needed. What do you think, and other options? After discussing all risks with the patients, there's a part that was initiated 1 month ago, and we are waiting the results. Thank you for your attention.
Thank you very much for your nice presentation. Any question, contribution, comment? Okay, yeah. Microphone, please.
I mean, certainly using a GLP-1 makes sense to address some of these risk factors. I don't think the family history of pancreatic cancer is a contraindication to that. They do have current gallstones, right? So they need to be aware of the symptoms of symptomatic gallstone disease in the setting of starting the GLP-1 so that, you know, because obviously it's a risk. So I think it's a reasonable approach. They can't drink any alcohol.
Yeah.
So
Yeah.
that's not right. And then obviously counseling, as we talked about, the protein in this individual because they had a sleeve gastrectomy. Now you're going to add a GLP-1. They've already lost 45 kg. So protein intake at least, you know, 1.5 gram per kilogram a day. The resistance training, I think, is going to be pretty important.
Thank you.
Okay, thank you very much indeed. We'll give an applause to you as well. So it was a very interesting and instructive session. Thanks to all the speakers and the wonderful audience. We'll have a coffee break now, and we'll be back at 10:45, please.